All right, this lecture we're going to talk about the right ventricle in specific. So before we talk a little bit more about the right ventricle, remember that the duration of the hypotension correlates with mortality. So sometimes when the patient's hypotensive and we're trying to figure out what's going on, integration of bedside ultrasound into the evaluation can result in a more accurate initial diagnosis with an improved patient care plan. Kind of take it as just like one of our senses as we use touch and hearing to do our physical exam. You can do ultrasound can be used as an extension of our sense of vision. So some of the things that we can identify with looking at the right ventricle is pulmonary embolism. We can see clots in transit. We can see signs of right ventricular strain. We can see dilated right ventricles. We can see signs of right ventricular pressure overload, such as a D shape in the LV and short axis during systole, and I'm going to show a dilated non-collapsible inferior vena cava. Some of the other lectures in the past, such as the one in inferior vena cava, can see that, but in this one we're going to focus on the right ventricle, and I'll show you some clips and images of right ventricles that are abnormal. Again, remember, if you're using an algorithmic approach, most algorithms have workup of looking at an enlarged right ventricle as a sign that you have a massive pulmonary embolism. The views that are best for right ventricular view are actually the apical view. The apical view is probably the best one because you can actually see the comparison of the right ventricle and left ventricle size and is the most accurate. In all of the other views, you can cut the heart at the wrong angle and get inappropriate information. Saying that, if you have a very large right ventricle, sometimes even on peristernal long, you will actually see enlarged right ventricle for acute pressure overload. Also, in the short axis view, as I mentioned earlier, you can see the D sign, and I'll show you some images of that. So again, it's still important to know all the different views that are available because sometimes you may not be able to get all the views perfectly. So when I talk about strain of the pump, you're talking about assessment of right ventricular strain. The normal left ventricle to right ventricle ratio is 1 to 0.6. Now you can just a lot of times visually see this, but if you actually want to measure that out on an apical view when you have the mitral valve and tricuspid valve, you can actually measure that out. But most of the time, when patients are in hypotensive shock or cardiac arrest, you're really not trying to get quantitative evaluations. You're just trying to look qualitatively if the right ventricle looks as large as the left ventricle or approaching that. Again, the optimal views are apical. The subcostal or subxiphoid can be used, but you may need to fan through to get the appropriate right ventricular size. When you're looking at right ventricular dilation, an acute pressure rise in the pulmonary circuit can cause this, but remember there are a lot of other causes also. The interventricular septum may have a right to left shift towards the left ventricle, and this can signal high pressures within the pulmonary artery. Here's a still image of a right ventricle that's fairly enlarged. You can see it's compressing on the left ventricle somewhat. But again, peristernal long, you can actually be cutting it at the wrong angle and compare it wrong. Also, sometimes you want to look for if it was a gradual increase or an acute increase. In gradual increases, the left ventricular wall sometimes becomes a lot thicker. So if you have a thin LV wall, that may show that it was a sudden increase. So how can you use this? Remember, the sensitivity of right heart dilation is moderate, but the specificity and positive predictive value in the high appropriate clinical scenario, especially hypotension or a patient that's been in the hospital for days and is now having cardiac arrest, surgical patients, orthopedic surgical patients, they all have pulmonary embolism as a high risk factor. It definitely correlates with a poor prognosis no matter what the cause. It may lead you towards giving TPA. There are some recent articles coming out that if the patient is in acute strain, that TPA may be beneficial, although this is a little bit of a controversial issue. But definitely a heparin infusion may be started for suspected PE. Sometimes the patient actually may be very unstable for CAT scan. in my experience, most times I'm making this type of ultrasound examination, the patient is too unstable for a CAT scan angiogram to look for pulmonary embolisms. If the patient is stable and the plan is made to get a CTA, evaluation of the right ventricle in detail is not as beneficial. Other things that you look for when you're looking at the right ventricle is there pericardial effusion? If you go to the lecture where we talk about pericardial effusions, I talk about how tamponade is what's the most important thing. And when you have tamponade, you're looking at the right atrium and right ventricle for collapse. Here's an image of a pericardial effusion with some mild collapse of the right ventricle. This may also indicate a low pressure system in the right side because this is a very small effusion and should not really be causing right ventricular collapse. Remember, what's more important to us is there tamponade or not? So the hallmark is right ventricular free wall inversion. This is best recognized during diastole. Right atrial inversion can also occur and is more common in early finding. So the right ventricle is very important to look at when you have a tamponade situation. Here's a still image of a patient with a pericardial effusion that actually has his right ventricle collapse. This is a still image, but I'm going to show you a clip of it in action. So here you can see the subcostal view. This is a pericardial effusion. This is the right atrium, and the right ventricle is collapsed. So remember, acute right heart failure shows early RV dilation, displacement of the septum, and tricuspid regurg. Although we're not experts at tricuspid regurg, if you do learn it, it is not difficult to do in the apical view to be able to identify large amounts of tricuspid regurg. Remember, absence of B profile in a patient with acute respiratory failure can indicate right heart anomaly can be expected. Once you're in the parasternal short axis, slight angulation or fanning superiorly should allow you to view the pulmonary valve level and then evaluate the main pulmonary trunk for thrombosis. We have actually used this approach, and I will show you a few slides of a clot where we see it in pulmonary trunk level. Before we show that, I do want to show you elevated right-sided pressures, or D sign. This is done in short axis view, parasternal short axis view of the left ventricle. Refer back to what normal is. Normally you see a nice circular left ventricle. And for instance, in this case, you see the left ventricle looks more like a D shape. Because of the acute right-sided pressure, which is pushing on the ventricular septum, and which makes a D shape, which should not happen. Here's another patient. This is a short axis. This is the right ventricle. This is the left ventricle. And it's a little bit harder to see, but you can definitely see the septum is not stable as you normally see. Here's a patient with a large right ventricle. It's almost twice the size of the left ventricle. If you go back and look at the normals, you'll see that the left ventricle is usually a lot larger. Although we don't see a D sign here, we do see a large right ventricle. So again, how can we use this? Remember, in the right clinical scenario, if you have a patient with elevated right-sided pressures, or you did the ultrasound the day before and you didn't see this, and now today the patient's hypotensive and you see that as a finding, it may lead you to diagnoses of right heart conditions. Again, you're going to look for tamponade. You may ask yourself, can you do this? At times, information and disorders noted are vast and may surpass your ability to appreciate and integrate, but the American Society of Echo says that the ability to assess global LV function, detect pericardial effusions, and right heart dilation are within the scope of emergency physicians. So remember, you're not only using this as your clinical decision-making tool, you're taking the patient's blood pressure, the patient's history, the patient's response to therapy, and helping you make a decision. Here's some pericardial effusions. So again, you see a pericardial effusion. You see the right ventricle collapsing, which could either indicate low hypovolemic status or high tamponade type situation where the pericardial effusion occurred fairly quickly. Here's a short axis view. You can see this is a large pericardial effusion because to get the papillary muscle level to have a concentric pericardial effusion at that stage means that it's fairly large. Here's another pericardial effusion, but without respiratory compromise, right ventricle compromise. Again, you might ask, can we do this? Emergency medicine physicians with limited training can detect effusions. Tamponade is a bit harder, but if you have a patient that's hypotensive with a large pericardial effusion, it should be concerning to you. Pericardiocentesis shows that even though we teach most people to do it subxiphoid, if you have ultrasound, you may be able to use the apical position. Really what you want to do is detect the distance to the effusion that is least and the size maximal. So again, what you see here is a patient that I was evaluating that had cardiac arrest, and right as soon as we got return of spontaneous circulation, we put the ultrasound probe on, and you can see here there's probably a clot, and if you look, I have standard, so this is the aortic valve, corresponds to this aortic valve. So this looks like a right atrial clot that's about to go to the right ventricular outflow tract. And so in this situation, you may want to use TPA or start a heparin infusion. In this case, the patient was in cardiac arrest, so we gave TPA. Here's a blown up image of the one I showed you before of a D sign. So again, you see the papillary muscles, you see the short axis of the left ventricle, and you see a septum that's not really creating a nice perfect circle. It's actually forming a D. Here's a large right ventricle. And again, the more of these you see, the more normals, the more abnormals will be easier for you to identify. Just a short axis view of normal. So I wanted to show you what normal looks like. Remember, this is parasternal long, short axis view, that's normal. This is normal size, this is normal LV. This is a short axis view. You see it remains more of a circle, more concentric. So hopefully that was beneficial to you to see some of those abnormals. But remember, this is just one of your evaluations as you're doing cardiac ultrasound for in the emergency medicine or critical care, hypotensive or cardiac shock, cardiac arrest patient. The signs that you're looking for are clots in transit, signs of RV strain like a dilated RV, or signs of RV pressure overload with a D-shaped LV. And those are some important things to look at while you're looking at the right ventricle during your ultrasound exam. Thanks a lot.